Yeah, good morning, and thanks to the organizers for inviting me and giving me this opportunity. I would invite my panelists, Dr. Deshpande sir, Dr. George, Dr. Kumar, Dr. Anshil Munshi, Dr. Bharat, and Dr. Kunal Sharma. Believe me, when I saw actually the list of panelists, I had a feeling that as if I am again going to give a DM exam, I have to present the case in front of all stalwarts and professors. But thankfully, this format of panel discussion, I have the opportunity to ask questions to the examiners and not to answer them. Till the time our panelists take their seats, these are my disclaimer. I'm a medical oncologist. I have a very little understanding of oncology as a whole, and particularly the surgical aspects, so please ignore my mistakes. And you can call this my prejudice that I believe personally that N2 disease in non-small cell lung cancer is a systemic disease. And we'll see this in the cases. The organizers have requested this interesting section here. So we are going to have an audience poll before our discussion, and then we can probably ask the same questions if time allows after the discussion. I mean, just to see how our panelists have influenced our audience. So can we have the poll, please? So, I mean, how many times we order the biomarker testing in otherwise resectable non-small cell lung cancer? And if yes, then what are the list of biomarker we test? You can. Okay, so there is a division here. So there are a number of people who do not want to test any biomarker, and some do want to check for this EGFR, ALK, and PD-L1. Excellent. Next question. So the preferred modality for mediastinal staging, PET only, EBUS, EUS combination with TBNA, mediastinoscopy, or everything, whatever is available. So still a big majority who actually does with PET only. Fair enough, let's see. The big question. How do you manage a case of non-small cell lung cancer that is T2, N2, M0 with single station N2? So this is single station N2, and we have two aggressive surgeons in panelists. I could not dare to put that option this time. I mean, we'll have this discussion. So can we see the results? Sorry, I missed the results. So a large majority want to give some neoadjuvant treatment and then surgery. Okay. So let's start the discussion. I mean, this debate we used to have, till this is a very old debate whether to give preoperative chemotherapy or do surgery first, then give adjuvant chemotherapy in resectable lung cancer. And majority of the time it was surgeon who were speak about like operate first, then they give chemotherapy, and then poor medical oncologist, which used to be, almost always used to lose this debate because of lack of robust data. That whether you want to give neoadjuvant chemotherapy and then operate a resectable lung cancer. So, there are certainly advantages and disadvantages to both these approaches. I would like to ask this question to my panelists now. Do you think that this debate is still relevant in 2022? I will start with our medical oncologist first, Dr. Bharat and Dr. Kumar. At least we should give this option to the medical oncologist first because they have been losing this debate so far.
Hello? Yeah, it's working. So So basically with the availability of this neoadjuvant immunotherapy and adjuvant immunotherapy, I think no, previously we used to practice chemotherapy as an adjuvant most of the cases, and case to case based on the discussion as our surgeon colleagues used to guide us to give neoadjuvant chemotherapy, we had practiced in very few subset of patients. But today I think we must discuss whatever available with us rather than, unless and until we don't have these options.
No, at least now you have one big trial suggesting that in operable lung cancer, you can use neoadjuvant chemoimmunotherapy with such an excellent
so basically with only chemotherapy, pre and post-op, I'm saying, in the past we used to practice only adjuvant chemotherapy.
Right.
Very rare scenarios we have given only chemotherapy because there is a rate of chemo radiation also. But with the availability of immunotherapy, definitely we have to discuss those options.
Okay. Dr.
And
Kumar.
again, it's a heterogeneous group.
Yeah, and
as the surgeon decides whether he is going to operate based on those, we are going to discuss
so fully
that.
agree. I mean, he is giving up. He is saying that it's the surgical domain and they decide what to do. Dr. Kumar, any thought?
Pre-op or post-op, by and large, most of the site doesn't matter. And same remains true for lung. Issue is that in which group of patient you choose what, till we restrict to chemotherapy. Issue is that where you think it's a systemic disease, the way what Dr. Prabhat said, my surgical colleagues will be worried doing surgery in 2 lymph node and 2 disease because most likely disease is going to come back in next 6 months. And that's the reason most of the time they won't do it. Where you have a disease which is primarily localized disease where systemic therapy adds value beyond that, primarily will go for surgery. So if you have a stage 2 disease, primarily that will go for surgery first, followed by adjuvant chemotherapy. Debate will remain, unfortunately, because the subsequent treatment development has been also both setting adjuvant and neoadjuvant both. Some of them is neoadjuvant followed by adjuvant. So debate will continue, but looks like pendulum is shifting more towards neoadjuvant therapy because now you do have multiple data that in neoadjuvant setting, if you give these newer combinations, it adds life to the patient.
So I agree. I mean, the debate would still remain, except for the fact that medical oncologists probably have some more data to present and some more arguments to give. So the surgical opinion, Dr. Deshpande, sir.
Hello. Yeah. Will this debate continue? I think Kumar has already answered that. See, the way I see it, eventually what is going to happen is the whole ethos and the movement of treatment is going to become less and less aggressive. So eventually will come a time that, I was just discussing with Dr. George, that if you give therapy, maybe immunotherapy, chemotherapy, whatever it is, and if you eliminate the disease in total, probably the next debate will be, do you really need to treat those patients with surgery? So we are veering towards that. We are exactly veering toward that. This is going to come. So whether as far as preoperative and postoperative is concerned, I think Kumar already answered that. It will continue, and only thing is you will need to pick and choose which one to do that way. Now you are talking in terms of a single station.
Right.
What will you do? I think in real life it's very difficult to be very sure that it's a single station, because you will operate that patient thinking that yes, it's a single station, and then you will find that 3 stations are involved. So what you have done is you have totally taken a wrong decision as per conventional kind of a wisdom.
Absolutely.
This theoretical, it's very energetic to talk about these things and gung-ho, but in real life it's not so easy to differentiate that. But probably I'll tell you one thing, what is going to happen 5 years down the line, 2027, you will come back and say that, all right, we have treated these patients, maybe better chemotherapy drugs, maybe immunotherapy, whether it's PD-L1 positive or not, maybe something else will come up. And then you'll say, okay, now we have sterilized this disease. Radiologically, there is nothing. Now you tell us what to do. We talk in terms of breast earlier. Now we'll start talking in terms of lung.
Absolutely.
And then the radiation oncologist will say, okay, SBRT is there. Why did you stop operating? Right. This is exactly how it is going to go. See, when a surgeon is going to go into extinction, he senses it much faster than others.
Absolutely. Yeah, I fully agree with you, sir. Dr. George, any thoughts?
I'm too young. I don't think surgeons are anywhere close to extinction. To me, for this answer to N2, I'm saying that if this is clinically staged with a mediastinal scope.
Yeah,
and
this is
absolute
like,
N2.
if you see based on radiology, based on some limited invasive mediastinal staging.
So, based on invasive staging, if this is what, I would give it neoadjuvant therapy, for sure. You can debate whether single station you could operate upfront. I'm in favor of giving neoadjuvant because that's a standard, the best evidence supports neoadjuvant. The only situation where I would operate upfront and give an adjuvant is if the patient is borderline fitness, you're not sure. We have to agree that surgery is definitive treatment. If you're sure you're not going to be able to deliver or do a surgery after neoadjuvant chemotherapy, I would err on the side, discuss with medical oncologists, do the definitive surgery, and then give adjuvant. But apart from that situation, neoadjuvant therapy.
Perfect. So, Dr.
Can I make a comment on lighter
please.
note? Anil is also here. So I think no, surgeons are never going to get extinct because we have lot many role for them in stage 4. And me and Anil will keep saying, George, operate some of them, all those oligo-progressive disease. He usually refuses it, hopefully. Year 2 years down
Kumar
the line,
is ready to give a lollipop.
So, in actual fact, the number of salvages, earlier we used to not operate salvage. The number of salvage resections we are doing post-chemo radiation and post-SBRT has increased by quite a bit in the last few years. So that probably is the direction we are heading in.
So, So, Dr. Anushil, I mean, where do you fit the chemo radiation for these patients who have otherwise, like clinically, single station N2 disease?
I think the first step is to definitely rule out the patients who are candidates, who will not be candidates for surgery at all. And they straight away come to the chemoradiation line. And we know what those patients are by literature and by our experience. Now, for the rest of the patients, the debate will continue on and on because we know from the data that we have from earlier very nicely done intergroup studies and other studies that all N2s actually could be potential candidates for some kind of chemoradiation, whether it is neoadjuvant or whether it is definitive chemoradiation. There is no doubt about it. But I'm sure the debate will go on and on whether it's neoadjuvant chemo after and followed by surgery or neoadjuvant chemoradiation followed by surgery or definitive chemoradiation.
No, because like now the immunotherapy and the targeted agents have already entered into the domain of early disease and locally advanced disease.
Prabhat, a single station can be 3 centimeter?
Sorry?
I was saying, just giving a bait to Anushil, a single station can be 3 centimeter, then most likely George may not like to operate.
Right. I mean, if lymph node is too big or a bulky, I mean, that's one of the criteria. But what I'm actually I'm trying to create this controversy for potentially resectable. I mean, surgeon is happy. He says that I can take it out. That's there in front of the radiation person that they can give chemoradiation. Now we have data of incorporation of immunotherapy post-chemo radiation. Now we have data of using checkpoint inhibitors in preoperative setting. I mean, now things are not that simple which it used to be because as medical oncologists, we didn't have much to offer. I mean, with limited response rates with chemotherapy, hardly we used to see some pathological responses. And now in the era when the pathological response rates are going to the tune of 25-30%, lung cancer is becoming a new breast cancer now. So things are even more complicated. I think this debate is going to become even more complex in coming years. So so let's move on to the case. Maybe we can take the same way we do in exam, some long case, short case, and maybe spotters, if time allows. This is about a 55-year-old male, never smoker, didn't have any comorbidity. He was evaluated for some persistent cough. Otherwise, he was minimally symptomatic. With good performance status and good effort tolerance, and these are the images. So he has a small, hardly 3 centimeter mass lesion in the right upper lobe, anterior segment, and when the PET scan was done, there was around 1 centimeter right upper paratracheal lymph node, which was showing some FDG avidity. Otherwise, there was no other metastatic site. So we did a biopsy. CT-guided biopsy, it was adenocarcinoma, predominantly SNR pattern, TTF1 positive. Well, now the question is to the pathologist. So this case seems like, I mean, this is a potentially operable case. If not upfront, maybe after neoadjuvant treatment, I mean, that's an altogether different debate. But when you get these samples, would you suggest doing predictive biomarker in these cases or not? And if yes, then what are the sets of predictive biomarker which you would?
So, biomarker testing is something that we don't suggest.
Okay.
We take that as the suggestions that come from the clinician.
I mean, this is institutional practice. I mean, we do get reflex biomarker testing for all cases.
Asks us, then we would definitely be able to, guide whether, especially, if some of the biomarker testings are needed or not. And I think this was a non-smoker, if I remember correctly. So as you saw in the poll, there are differences of opinion that some people do like to go for EGFR, ALK and PDL1 kind of a panel. But I mean, that's still debatable, but we keep it open to the clinician.
Okay, so we'll start from the clinician. Maybe we'll start from Dr. Deshpande, sir. Would you ask for a biomarker for this case or not?
Hello. Yeah, exactly what he said. PDL, the EGFR, ALK, and PDL1.
No
this is
NGS
what we
at
would
this time?
normally ask for every patient.
So you will ask for EGFR, ALK, and PDL1. So
Yes.
that's the minimum. Yeah, I mean, that makes sense. I mean, whatever decide your treatment at this stage would be more sensible to do. Dr. George?
I wouldn't, as a routine, ask for because oral TKI in the neoadjuvant setting, I'm not certain there is enough data. Immunotherapy, there's data coming up. So I would depend on Kumar if he wants to give neoadjuvant chemo immuno. And so if he wants it, okay, PDL1. As a routine, no.
Okay. Let me ask Dr. Kumar directly.
My question would be that the trial that advocated immunotherapy in the neoadjuvant, did it ask for, I understand it didn't care for PDL1.
So, these are absolutely valid comment. What report you have and how you decide your treatment. Two aspects is there. One is what was done in the trial. So, a trial, we give immunotherapy. One of the things to preclude immunotherapy is if it's EGFR ALK positive. So, for that reason you give it, not to choose treatment, to exclude treatment. So, you don't give immunotherapy if that is positive. So, these are the three markers. If you take traditionally, one should do it. I will add one more aspect. In case if you're giving neoadjuvant treatment and you're having the same tissue, same cost involved, and then you do have reasons that these patients, as much the wonderful treatment we are giving, almost more than 1/3 are they going to come back, and you do require a biomarker that time. And trust me, you have almost 1/3 of the patient where you have a disease where you will not get tissue at that time to do biomarker. So if you can do it now. Don't work on it. Leave it there. Tell your patients that I am doing biomarker beyond these three, but I'm not going to give treatment based on that, but it may help you in future. So do NGS. You will have those 10 gene panel. Same cost what you get for these three if you do separately, but you will be working based on those three markers. 2 to exclude treatment, 1 to give treatment.
Yeah, Dr. Kunal, you want to say something?
So I think that's an important point that you can do it, but you should not probably base initial treatment based on that. Another very pertinent point which I usually like to stress in most of my talks is if you are suggesting a broad spectrum NGS panel for these patients, you should always wait for the NGS report before starting treatment, because PDL1 report will be available to you much before your NGS report. So you should just wait till your NGS report also comes before instituting treatment.
Yeah,
in
Dr. Bharat.
real life practice, what happens if you send NGS, it takes some time, in some of the lab, 1 month. If you do a precise panel, there are panels available which includes most of the EGFR mutations and PDL1, that is very important, which will be available within a period of 2 weeks. I think that is also very important which lab you are sending the sample when you are taking a decision on neoadjuvant therapy or the resection. In resection specimen, you can do it on the resection specimen. But
No, but if you give neoadjuvant treatment and there's nothing left, I mean, you do get pathological CR, so you may have, you may end up having nothing.
So I agree with Dr. Kumar, because in the future, majority of these patients.
Yeah, I agree. I agree with the panelists, which they said that the biomarker which need to be tested should be guided that what treatment modality you are going to offer, what your tumor board decide, the approach which they decide on. If they are going for an upfront surgery, probably that's fair enough. You would have enough tissue for the entire spectrum. And if you are going for a neoadjuvant treatment, probably a guided treatment would be a better choice in the current era. As far as the immunotherapy is concerned, even just Checkmate 816 trial did not stratify, did not require PD-L1 available, but it was, a subgroup analysis. For exclusion, they excluded patients with EGFR and ALK. And to my understanding, if I have to say what is the best predictive biomarker for immunotherapy, I would say it is the absence of driver mutations, which should guide whether that patient should be taken for immunotherapy or not PD-L1 alone. And particularly when you are using chemotherapy with immunotherapy, be it a metastatic setting or be it in a locally advanced setting, probably the value of PD-L1 remains questionable. So, that depends what facilities you have and what are the treatment options available. So in the neoadjuvant setting, probably you would not exclude or include patients apart from EGFR and ALK. So, that limited information is good enough at this point. So, fortunately or unfortunately, at our institute, all lung adenocarcinomas undergo this biomarker testing for EGFR, ALK, and ROS1. PD-L1, they do test on request if a patient is able to take immunotherapy or not. So this patient had an EGFR L858R mutation. Okay? So, let's come back. We do have this information. This is clinically T2, possibly N2 single station based on PET. Now the question is, how do we further evaluate this patient? How to evaluate the mediastinum? Back to Dr. Deshpande sir and Dr. George.
Regarding, we are talking in terms of T2, N2, that's our...
this is the information topic, right? We have the biopsy.
So, all lung cancer patients before surgery will undergo a PET CT scan. There, the mediastinum will be either a positive mediastinum or a negative mediastinum, right? Now, if radiologically the mediastinum is completely normal...
So this is possibly positive, sir. There is one upper paratracheal
if it is positive, almost always we try to establish a tissue diagnosis. Okay. In our center now, what we are doing is we do an EBUS and mediastinoscopy, and we rely upon that because we have got very good endoscopists who have got an excellent kind of a record, and we rely upon that. It's fairly okay. There are centers I am aware that who follow EBUS followed by mediastinoscopy, but I think there are very, very few centers who do that. We used to do that earlier, but we have given it up. Okay. So this thing is EBUS with FNAB is our standard of care as of today. Following the positive PET CT scan.
So what are particular mediastinal stations where you would not be very comfortable if you are seeing those lymph nodes in CT scans or PET scan, where you are not comfortable in just EBUS TBNA?
The lymph nodes around the aortic arch are the only ones which are, to be very honest, not actually accessible to this thing. But if you combine EUS with it, esophageal, by and large, you are still able to get by there also. So I think that's perfectly okay. Right. Because the centers which are difficult to access by EBUS are the same centers which are difficult to access by mediastinoscopy also. Okay. So this is a very, very important point to realize. And you try to become very aggressive. See, ultimately, you must give a test which is doable by everybody, which is the skill of which is transferable to everybody. So there is no point in only an HOD coming all the time, doing a mediastinoscopy and going. It has to be a standard of care for the whole unit and for the whole service, which means that many people should be able to do it with a reasonably same amount of competence and low risk. Diagnostic tests normally, ideally should be at zero risk. Right. But mediastinoscopy, in the best of the hands, has 0.1% risk in any case. But you try to extend that indications like this particular thing, what I'm mentioning in clinical circumstances, that risk will grow up multiple folds of time, which is not an acceptable thing.
Okay. Dr. George, your thoughts?
Yeah, so I have the privilege of working in an academic center. So we do both. We do both EBUS and mediastinoscopy if the EBUS is negative. Now, experience in mediastinoscopy is significant. We've done more than 1,000, and EBUS probably around 150. Honestly, the mismatch is 7%. So we get 7% more nodes positive when you do a mediastinoscopy. That's it. So given, let's be realistic, at least do one.
Okay.
The gold standard is mediastinoscopy. We can do much better. And another point which a surgeon needs to know is that there are EBUS nodes which are picked up or not picked up. And when you put a mediastinoscope inside, it might be a 1 centimeter node. The last one I did was a left lower lobe subcarinal 1 centimeter node. It came positive, but I decided no surgery because it was unresectable. So that's one aspect which in EBUS cannot give you the information. The mediastinoscope you put in, you can say that it's a 1 centimeter stone, but it's plastered on the bronchus. You can't take it out, goes for chemoradiation. That's a bit of information which only the mediastinoscope can provide. Of course, there is an element of risk.
So if EBUS is negative, so would you be comfortable in taking that patient directly for surgery, or you would do a mediastinoscopy and then enter?
So fortunately for this patient, the EBUS was negative, but I still went at mediastinoscopy. It came positive in the subcarinal area, but it was plastered, backed out, chemoradiation. I can't get an R0.
Okay. Question to the pathologist. When you receive a sample from TBNA, I mean, we do get sometime blood only or some scant lymphoid tissue and so on. I mean, what's an optimum sample where you can say, okay, this lymph node is clearly negative?
We base, our findings on the number of cells and the cellularity that we see.
Okay.
So roughly, about 100 cells should definitely be present whenever we are seeing cytology. Also, what we try to do is that we try to prepare cell blocks out of the cytology samples that we get. And based on that, and correlating it, it's very important to correlate it with radiological findings, especially because in these days, cytology is, especially when, we are talking about, the immunotherapies and targeted treatments and, things like that, you should definitely be very, very sure before calling something is completely negative.
Sure, perfect. So evaluation for brain, that's the next question. Dr. Kumar.
Sorry.
I mean, this is a potentially operable patient. So this is clinical T2N2. Would you evaluate for brain to rule out brain metastasis? He doesn't have any CNS symptoms.
Yes, this patient, yes. I'm not saying all resectable patient, but this patient, yes.
Okay. So, I mean, although the quality of data to suggest that when and where we should actually do the brain evaluation is mostly limited to the case series and all, but most guideline would suggest that at least wherever you are doing a radical treatment or a curative intent treatment, exclude brain metastasis, use a more sensitive method like MRI, because it can change your treatment entirely. Almost half of the patients may have asymptomatic brain metastasis, and the chances are higher as the stage goes up. I mean, this is one of our own very small analysis of almost 500 odd patients who were, I mean, these are consecutive patients who were imaged for CNS metastasis irrespective of the stage and symptoms. And we got and this is based on CT scan and not MRI. That's another story because of several logistic issues. But even with CT scans, we are able to detect brain metastasis in 20% of the cases, and half of them were asymptomatic. And it could lead to upstage in around 7% of patients. And mostly these were stage 2 and 3A, stage 2A to 3C. Who were upstage by a simple CT scan. Some of them have undergone MRI also, but that's a very small proportion. I mean, that just gives us some idea that imaging brain can actually entirely change our treatment plan. Well, so we did an EBUS along with TBNA for this patient, and they also saw an enlarged right upper paratracheal, that is 2R, and one right interlobar, that's 11R. And they sampled the 2R station, and it was positive. His PFT is normal. I don't see any major abnormality with good cardiac reserves. This is a pretty young patient, 55-year-old, never a smoker, no comorbidity. Now the big question. I will start with surgeon this time. Would you like to take this patient for upfront surgery? Deshpande sir.
I think you have established that it's only a single station.
Yes, sir. I mean, with EBUS and TBNA, we have established that there's a 2R single lymph node, which is 1 centimeter, and it's positive. For
How old is this patient?
55.
And tumor size?
Tumor size 3 centimeters, sir.
3 centimeters, okay. So, all right, so it's still bordering onto T1, T2, and N2 single station. I think as per definition, it all depends upon what's a policy of your department. In our department, we'll take the first choice, upfront surgery followed by adjuvant treatment.
So you suggest upfront surgery followed by adjuvant treatment, Dr. George?
Yeah. I would go in for neoadjuvant treatment.
For?
Neoadjuvant treatment.
Neoadjuvant treatment.
And systemic therapy, I would leave the choice of drugs to Kumar and co, but neoadjuvant therapy followed by surgery for me.
Dr. Anushil. Is this applaud? Dr. Anushil. I mean, I have kept this option this time.
So as I said earlier as well, now if the surgeons are in a very comfortable zone, that this patient
Surgeons are
is
in very
truly
comfortable zone. We
operable,
have surgeons who are operating.
what I have to say is, even for such patients, chemoradiation and definitive chemoradiation would give you equivalent results as far as the present literature is concerned. There is no data that suggests a definite inferior outcome with chemoradiation in such a scenario.
Yeah, I mean, I would put it in some other way, like based on the data where we are saying that it gives you equal results, I would say it gives you equally bad results. I mean, those were the times when, there were lack of good systemic therapies based on the trials which we are saying that they are equal results. I mean, look at the outcomes for these patients, and these were the mixed bag. I mean, if we have to dissect out these patients who are to go for surgery, the small lesion, possibly resectable, single node.
So then my answer would be, let us wait for more mature modern data before we answer this question. Where is that modern mature data randomized that tells me that I should not give chemoradiation in such a scenario?
So probably, I mean, this is the right time, then we should have such trials again. I mean, no, you have a better understanding of disease biology, you have biomarkers, you have good systemic treatment, you have good radiation modality, a better surgical techniques. I mean, this is the best time to, redo such trials. To end this debate, whether to operate or whether to irradiate. Dr. Kumar,
So,
if neoadjuvant, then what? If adjuvant, then what?
So, first of all, neoadjuvant, this will be my preference, and because that's what we practice, but with some reasoning. And what's the reasoning? What is by and large not debatable, that if you have N2 disease is a systemic therapy. You want that patient to be exposed to systemic therapy. I'll give you the reason why. If you don't give neoadjuvant, almost 40% of the patient will not be going to get systemic therapy. Now that becomes pretty tricky, that almost half of your patient is not going to get systemic therapy. You are not giving neoadjuvant. Because if you give neoadjuvant, then almost only 4 to 5% or 7% you will be stopping it for side effects. Otherwise, you will be able to deliver it. So that's one of the reasons where your systemic therapy is important. Now, why I said neoadjuvant depends upon what much value it adds. Now, if you take neoadjuvant chemotherapy in this setting, the value it adds in adding life, it's around 10 to 15%. That is the absolute difference. I'm saying stage 3 patients, not stage 1. Ballpark figure is 5% for improvement in survival. Divided in stages, it varies from 1.5 to around 13 to 14%. That is only for what? Chemotherapy. Now, in case the patient can take immunotherapy, recent data came, it's called Nadim-2 trial for overall survival. The added absolute benefit, again I repeat, absolute benefit, small study, but overall survival data came, it is around 20%. What does it mean? N2 disease with one group of modality, if you're adding, you are adding value of around 20, 25, 30%, that kind of benefit you are giving. If you don't do it, you are putting us patients which require systemic therapy, which has got potentially systemic disease, which may not be able to take it if you do surgery and subsequently give treatment, and that will be ballpark figure around 40%. That's the reasoning, what I gave a reasoning. I totally agree when George was mentioning which treatment to choose. I know, and he was absolutely rightly mentioning, because as much we want it, as much the data looks good, only 3% of our patients can afford immunotherapy, and that should always be at the back of the mind as much we talk about that data. So for all practical purpose, that data is good, but maybe not so meaningful in our clinic at present.
Just to interject here, I think what Kumar has said is basically a a very practical point, but it's not an oncological point. You know, the compliance of the patient post-operatively is definitely less, is understood thing from Tata Memorial Hospital. This is not the same thing that we see. In fact, it almost never happens that the post-operatively the patient, they grumble, but they do take treatment. Our incidence of fallout is less than 5%. Adjuvant therapy, whether it's chemotherapy or chemoimmunotherapy, this basic thing.
But sir, in general, I mean, based on the even trial data, the general perception that tolerance particularly is relatively poorer post-operatively than pre-operatively.
See, you are looking at a person who has undergone a major surgery here, okay? And most of these surgeries will be endoscopic surgery, thoracoscopic surgeries, okay? Well, if the guy is fashionable, then you would offer him a robotic surgery or whatever. But basically, essentially, the component remains the same. So the trauma because of surgery is a certain component which most of the people will be able to withstand. So that is not a problem. Okay. Added to the whole thing is, this is a guy who's 50 years of age, a decent-sized tumor and not too much. But the technique remains exactly the same for whether it is a single station, multiple station, whatever it is, when you actually go inside. So that does not really change at all. So from that point of view, over a period of time, a single station, when you confirm it, that it's only a single station, then the thing can undergo a little bit of a change. Right. Otherwise, conventionally, any N2 disease is giving a preoperative chemotherapy or preoperative chemoimmuno is a no-brainer.
Yeah, so the question here is, this patient is EGFR L858R positive. So Dr. Bharat or Dr. Kumar, I mean, chemotherapy, TKI, both, what? Obviously, it's a no for immunotherapy.
So for TKI neoadjuvant trials are still are there going on. So it is very early to say whether I would recommend only TKI to these patients. If the mutation is positive still, and the surgeon wants to operate after my neoadjuvant treatment, and if, as you know, most of the patients are not affording for immunotherapy, systemic therapy still is a choice. Now, chemoradiation has been tried in a neoadjuvant setting. Now, you can operating a patient with chemoradiation.
Neoadjuvant chemoradiation.
Yeah, there is a little.
So, if neoadjuvant is a problem, then definitive. Carry on to the definitive chemoradiation part. What I'm saying is, it's an option. It's a valid option. I'm not against surgery or something, but what I'm saying, it's an option.
So this debate is going on, and it will go on. Chemoradiation versus surgeon.
Perfect.
But at the end of the day, in the multidisciplinary team, we have to come to a conclusion of whether the surgeon is going to operate before chemotherapy or after chemoimmunotherapy, whatever.
Sure. So there are very few studies of use of TKIs as a neoadjuvant treatment. We know that EGFR mutated patients have very good response rates, what we see in metastatic disease. But unfortunately, neoadjuvant studies have not really shown a complete pathological responses. But there is a very interesting phase 3 study going on called NeoAdora. In fact, we are one of the centers enrolling patient, and this patient happened to be one of those patients who were enrolled in this study. So, this is a 3-arm study giving placebo with chemotherapy with osimertinib or osimertinib alone. And then they are looking at pathological response and survival outcomes as well. Just to highlight that Checkmate 816 excluded patients who were EGFR positive. So this is just to reinforce that idea that all neoadjuvant is not chemoimmunotherapy, do biomarkers. And these were the response. So this was a blinded study. We do not know. We know that this patient received chemotherapy, but we did not know whether he received osimertinib or not. So this is the response. You want to, Dr. George?
I want to comment. I always try to persuade Kumar, whenever we have a ALK positive to give neoadjuvant.
Right.
He never does it because he says there is no evidence to give it as of now. We are also a part of this trial. Let me say, for a T2N2 disease, I understand the systemic, it's going to recur systemically and need systemic. For definitive management or local control, you need surgery. You can give the patient anything, including Amrit, it's finally going to land up on table, and I'm going to resect it. That's the story, even after chemoradiation.
Okay. So, because we have very less time, so this patient had a very excellent response. We did not do mediastinal restaging. That was another point I wanted to ask, but then we got this surprise. This is the post-op histopath. This patient had a good pathological response at the primary site and had 4 lymph node positive, 3 at a 2R station and 1 at 4R, residual N2 disease. The last question, the adjuvant treatment for this patient, and then we can end the session. Dr. Kumar, I mean, obviously, the adjuvant treatment, the systemic.
So a patient received neoadjuvant, isn't it?
This patient received 3 cycles of neoadjuvant chemotherapy along with investigational product. We do not know whether it was placebo or osimertinib, but this is the situation now.
So, it traditionally none. In case you so strongly believe with Nadeem 2 trial, you can give adjuvant immunotherapy. Not what we do at this moment. For me, good enough treatment at this moment in this patient for RT.
I mean, he has residual N2, RT.
So with the lung ART trial, the enthusiasm for using RT.
Thank you.